Hi, everyone. My name is Will Steinberger. I'm happy to introduce Professor Angela Di Fovio, who's going to be presenting on a combination of medical imaging and physics today.
Thank you, Will, and thanks everyone for joining in the talk today. It's a pleasure to be here. Thank you for inviting me. I'm going to share my screen, and please let me know if you see it correctly. Okay. All right, you should be able to see my screen now. And today I'm going to talk about our attempt in synergizing imaging, dosimetry, and radiotherapy with the help of machine learning to address some of the current challenges in hadron therapy in general. This work was mainly performed by Jiangxin Zhu, Koloda San, and Humber Hunter, who are respectively graduate students and undergraduate students at the University of Illinois at Urbana-Champaign. I'm going to give a brief outline of the talk since it may be slightly different from the previous talks of this series. And therefore, I'll be introducing a little bit about therapeutic radiology in general and basic differences between the commonly standard X-ray radiotherapy as compared to hadron therapy. And next, I will identify two challenges that we've been tackling so far. And one is integrating machine learning in the clinical workflow, and in particular in the segmentation of the organs in radiotherapy. And a new concept of a telescope detector that could help in quality assurance and eventually microdosimetry in hadron therapy in particular, and why is it relevant in that case. So let me give you a quick overview of the use of ionizing radiation in medicine. These are mainly two that can be classified in two branches. The diagnostic branch, where we use, for example, positron emission tomography or computed tomography to analyze the anatomy of the body and of the tissues, and also the functionality. And then therapeutic radiology, that encompasses X-ray radiotherapy, as well as hadron therapy, brachytherapy, boron neutron capture therapy are a few examples. There is, apart from the technical differences between each of these different techniques, there is one main difference, and it's that the limitation principle, which states to limit the dose to individuals in planned exposure situations, does not apply in therapeutic radiology. In other words, patients do receive very high doses in radiation therapy, and these doses are planned specifically to be detrimental and to kill tumor cells. Unfortunately, as we will see, they also have the potential to damage healthy tissue. So our efforts are geared towards limiting these damages to healthy tissues while maximizing the damages to the tumor. Another, when we think of therapeutic radiology, we must think that we refer to approximately 50% of all the cancer patients that undergo radiotherapy. So 50% of cancer patients, which are approximately 3 million patients per year in the US, do undergo radiation therapy. This is a huge population, and therefore advancements in this field have the potential to benefit a large population, a huge amount of people, and have obviously a high impact on society. The mechanisms by which ionizing radiation kill cancer cells have been known since the discovery of ionizing radiation. It was Marie Curie who first envisioned the application of ionizing radiation to treat cancer. However, the exact molecular processes are yet to be fully understood. I like to discriminate them in two main categories. Those that the damages that directly affect the cycled cell, the cell cycle, that you see represented in the left side of the picture, and the directly molecularly controlled that pathways. So what I mean by this is that the cell typically replicates through, the cell does replicate through mitosis. And this means that a cell splits into other cells which have exactly the same genetic characteristics as the initial single cell. This mitotic process, as you can see, undergoes through a cycle. And this cycle starts with a rest, the cell at rest, and then the division of the RNA, followed by the synthesis of two identical DNA chains, which then constitute the genetic heritage of the two split cells. If the radiation interacts with the cell while it is replicating, then it has the cell is more, as we call it, radiosensitive, and therefore it is more likely to be permanently damaged by the radiation. This radiosensitivity is more severe for those tissues that replicate at a high rate. Among tissues that have a high replication rate, we can list the skin, for example, but also cancer cells. So compared to healthy tissues, on average, cancer cells do replicate faster, and therefore they are more radiosensitive. On the other hand, there are other processes, that pathways that are less well understood, and those are apoptosis, which is a programmed death. The cell programs itself to die, autophagy, and senescence. All these have a relationship with ionizing radiation when apoptotic cells do undergo irradiation, but are not as well understood and seem overall to play a less important role as compared to the mitotic process that we've just described. When radiobiologists do design treatment plans, they mostly refer to this graph that you see on the right side of the slide. And this tells us the fraction of that cells that we have as a function of dose. And in this graph in particular, you see the deaths due to the two processes, the mitotic link process and the apoptotic process, which we just mentioned. And overall, they all contribute to this final curve here. So the higher the dose, obviously, the more cells will die and the survival fraction will decrease. This curve is an experimentally derived curve, and therefore it carries all the complexity of the biology and the interaction of the ionizing radiation with the tissue. However, it's usually modeled through a relatively simple linear quadratic model. And the linear quadratic model encompasses a first stage when we have a non-repairable damage, in this linear component in a log scale, and then a quadratic component that is typically considered referred to a repairable damage. So starting from this curve, we can study the effect of ionizing radiation on cell, and we can plan the treatment. As a matter of fact, this range, the range from 0 to 3 gray, is the range that's used in typical radiation therapy treatments. And this is because it allows to do the non-repair to perform the non-repairable damage here in this first stage, and then it allows healthy tissue to recover. And in the second fraction that is going to be performed over time, again, it will have the maximum effectiveness in killing, again, cancer cells. So the fraction of survivability, the survival fraction curve, is the basics to plan and to evaluate different treatments. And I wanted to introduce it to you because we will have a look at it also later, as comparing damages from protons compared to X-rays. The usual figure, the graph that one refers to when comparing X-ray radiotherapy to charged particle therapy is the one that you see here on the left. When referring to radiotherapy, usually we think of X-ray radiotherapy, and this is still the most common and most used technique, and also is quite effective for certain types of tumor. However, some features of charged particle therapy make it make it desirable to treat other types of tumors, such as the tumors of the eye, but also in some cases prostate cancer and some other deep-seated tumors. And therefore, it is an emerging technique that's getting more and more attention worldwide. Currently, there are 88 therapeutic centers approximately, as of 2019 at least, where patients are treated with particle beams. Of these centers, there are 13 also have the capability of delivering not only protons as charged particles, but also carbon ions. These ions, so protons and carbon ions, are the only ones that so far used in clinical practice. So back to our the dose delivery pattern, this is the relative dose as a function of the depth in the tissue. And you can observe how the highest dose for X-rays occurs at the entrance, whereas the peak of the dose is, in the case of ion therapy, is right at the tumor location. This intuitively makes us realize how more effective and conformal a treatment with charged particles can be. Obviously, when we deliver an X-ray treatment, we need to rotate the gantry around the patient in order to achieve the highest dose at the tumor location. And this is not strictly necessary in charged particle therapy. This peak is the so-called Bragg peak. The physics tells us that is the location in space where the particles lose most of their energy, but also have the highest ionization density. And that's where they deposit most of their energy, again, causing the highest damage to the cells. The ionization density can also be quantified by the linear energy transfer, which is the energy deposited per unit path. The higher this linear energy transfer, the higher is the probability of having a double strand break of DNA chains. So if you remember that mitotic type of damage, that is going to be more likely at the Bragg peak. And this is why, by changing the energy of the primary beam, it is possible to focus the beam at the tumor location and also build a structure which can encompass the full tumor length. In this picture, in fact, you see the relative dose with respect to the 100% of its max as a function of depth. And you can observe how by piling up different Bragg peaks, we overall obtain what is called a spread out Bragg peak, which is a uniform dose distribution at the tumor location, and which is desirable to have. So to conclude on our comparison, the ion energy loss at the end of the penetration range, known as the Bragg peak, compared to X-rays of charged particles, yields a better conformality and also better ballistic precision. This higher ballistic precision is certainly a great advantage because it allows the possibility of treating cancers located near critical organs, but can also be a drawback because if we are not precise in the beam delivery, then potentially we can damage healthy tissue. And finally, the higher relative biological effectiveness of protons and charged particles compared to X-rays, and we will get in the details of the RBE in a couple of slides, has the potential to enhancing the cell killing process. When we think of charged particle therapy, so it is expected to see a better conformality of the dose distribution. And here you see a treatment for a spinal, for the bone marrow treatment, actually. And on the top two pictures, you see two cross sections of dose distribution obtained with intensity modulated radiotherapy. So X-ray therapy, and you observe how, because of the rotation of the gantry around the patient and because of the highest energy at the entrance, unfortunately, we have a non-negligible entrance dose delivered to empty tissues. Conversely, in proton therapy, the maximum of the dose is all located in the region that needs to be treated. So I hope that I convinced you that certainly proton therapy and charged particle therapy can achieve a better conformality. But going back to the concept of survival rate, we also observe that for particle therapy, this is generally referred to as particles. These are actually protons. We need a lower dose to achieve the same killing rate compared to X-rays. And this is the concept behind the relative biological effectiveness, which is that difference between charged particles and X-rays to achieve the same clinical endpoint. So what is the dose that I need to deliver to obtain the same cell fraction killing? And this is the DRB. DRB for protons is generally and conventionally, I would say, it is assigned an RB of 1.1 to protons as compared to X-rays. So 10%, so protons are approximately 10% more effective than photons in killing cells. This is not set in stone. As a matter of fact, many studies have shown that there is a huge variability in the RBE for proton therapy. However, the IAEA, which issues some of the guidelines for this hadron therapy treatments, still recommends to use 1.1 as a factor for treatment planning. because it's considered, on average, relatively accurate. And these studies, when the comparison was performed for the RBE, really were related to the dose in the middle of the SOBP, and not at the end of each Bragg peak that is delivered. As a matter of fact, if we consider a variable RBE, which would make, which is more realistic, definitely more realistic, the dose that should be delivered to obtain the same effect would dramatically change. Some centers are starting to consider a variable RB, but the clinical practice still adopts a 1.1 factor in general. So the RB is very important, and it does not only apply in reality to the primary beam. As a matter of fact, when we think of radiotherapy, we must take into account that together with the primary beam, a non-negligible amount of secondary radiation is delivered to the tissue. And the secondary radiation in X-rays mostly consists of gamma rays, mainly just scattered primary gamma rays, and neutrons, if the energy is high enough. In proton beams and in charged particle beams instead, we can also have charged recoils, which, as you've learned from these first slides, have a much higher LET, so a much higher RBE that can potentially damage non-tumor cells. In this figure, you see the measured dose in a phantom. A phantom is simply, in this case, a 30 by 30 by 30 centimeter square water parallelepiped, which was irradiated by 20 MeV X-ray, by a 20 MeV X-ray radiotherapy beam and a proton therapy comparable field. And as you can see here in blue, we see the results for the scattered gamma ray here, the out-of-field gamma radiation, and in red, the out-of-field neutron dose as it measured. Here we have the primary beam, and at a distance, we observe how the gamma ray dose, as expected, is much lower in pencil beam scanning compared to X-ray beam scanning, but the neutron dose really doesn't change much. So per each delivered gray, we have millisieverts. We can reach up to millisieverts of neutron dose. And when we have treatments that have encompass tens of grays, this dose easily builds up to a potentially detrimental dose. So we talked about neutron production, but we also need to consider that there could be nuclear fragmentation, and there is nuclear fragmentation in charged particle therapy. And the nuclear fragmentation it can occur mainly, it is target nuclear fragmentation, which means that these charged particles are products of the interaction of the primary beam with the elements of the tissue. But for carbon ions, we can even have projectile fragmentation. So it is the carbon ion themselves that fragment. And this figure shows well how while we deliver our Bragg peak, our single dose profile, the primary beam mostly contributes to the dose at the end of the path, but the fragments indeed are almost are more relevant at the beginning of at the entrance of the tissue of the body. So in other words, the fragments are going to affect, once again, non-target tissue, which needs to be spared. And this figure also has a nice representation of the ratio between the recoil fragments and the cells killed by ionization. So at the Bragg peak, we have the maximum ionization density, and the recoil fragments are really negligible. But they are only 1/8 of the particles at the entrance. And larger contributions of these fragments is expected from carbon, beryllium, oxygen, and nitrogen. These the physics behind the fragmentation, especially at energies above 100 MeV, that are those therapeutic energies, are not well understood. So even in the modelization and in the simulation of these treatments, we do not currently have a validated data set that can be used to simulate with enough confidence the fragmentation contribution. So there is a lot of work to be done there. In this first slide, I wanted to introduce you to the general principle of radiation therapy. And now I want to give a quick overview of how a treatment is actually delivered. When clinicians, and by clinicians, I mean medical physicists and radiation oncologists, do plan a therapy, a treatment, they first of all design the treatment using treatment planning systems. The treatment planning system is done upon performing quality assurance on the machine, which is typically a process that takes approximately 30 minutes and is done daily. And it is very critical to make sure that the delivered dose is what it is set to be delivered. The treatment planning system then designs through TPS treatments are designed, and then oncology information systems are incorporated to finally be all merged in a treatment delivery system that does nothing else than determining the time and the shape of the beam to be delivered. And finally, obviously, we have the patient receives the radiation. Now, in a standard workflow in radiotherapy, in standard radiotherapy that you can see here, this loop is a closed loop because the clinician checks the anatomy of the patient through imaging and through the TPS, and then checks the dosimetry of the treatment plan, and finally that the treatment is delivered. And the critical component that makes this loop closed is the in vivo dosimetry. In vivo dosimetry nowadays is possible in radiation therapy, while it's not in hadron therapy. So this is a big lack that we currently have and that we've been focusing on. We're not able to check in real time, as we do in standard radiotherapy, what is the dose that is delivered to the tumor. And even if we were using standard systems that are used for X-ray radiotherapy, we would not be considering that RBE effect that we just discussed about, and that's so important, not only due to the varying RBE of the primary beam, but also of the charge secondaries. So there are several challenges to be addressed in order to close this loop. The second challenge that's not negligible is really the integration of this chain, which is also currently partially manually executed in the clinical practice. So these stages and these blocks are not currently well integrated with each other. And this is where machine learning can play an important role to streamline some of these processes. And in these white boxes here, I have I highlighted the tasks that machine learning can help with in each of these stages. I should point out that radiologists in general, there's two different approaches and also attitudes towards machine learning. Some people like to see it as a black box that can solve any type of problem, but clinicians are not generally open to not to losing control over the procedure. So that said, when the treatment planning system is used by radiation oncologists, there are several steps that that need to be done before. So first of all, the treatment, the TPS is based on a reconstruction of the patient anatomy, so typically on CT scan images. Then that image needs to be registered. By image registration, we mean the fusion of different types of diagnostic images. So not only CT, but also PET, if necessary, and MRI. They need to be all fused together and refer to a common reference system. That's registration. Segmentation is also one particular and very important step here, because it aims to delineate the boundary of an organ or lesion of interest in medical images. And it plays a crucial role in radiotherapy because it is needed to identify the target region and avoid healthy tissues during treatment. Currently, these structures are identified slice by slice in a 3D structure by radiation oncologists. You can clearly understand how this process is time consuming, and also it lacks reproducibility intrinsically. And finally, there are new applications that envision the use of machine learning for analyzing and embedding prognostic signatures. So these are all important tasks where machine learning can play a relevant role, together with real-time motion tracking at the delivery system time. So we focused on segmentation. And as we've already said, segmentation is important when we need to delineate organs at risk and gross target volume in each patient CT scan. And the automatic segmentation would reduce the necessary time. And we tested it on two types of cancers, nasopharynx cancer and lung cancer, for radiation therapy planning. This doesn't really change at this stage between X-ray radiotherapy and proton therapy. So this is applicable to both therapeutic approaches. We had available 22 organal risks of 50 nasopharynx cancer patients, and they were annotated. This means that a radiologist had already labeled these areas correctly. And these 50 images were used to train a convolutional neural network that was then used to automatically segment the regions. And then 10 patients' CT scans were used to test our algorithm. This is an example of the scan that we received with the labels and with the segmented area, manually segmented. And visible areas include regions like the right eye, the left eye, the lens of the eye, as well as the optical nerve, and so on. All these regions are considered organs that are radiosensitive, and the treatment plan needs to be designed as best as possible to minimize the dose there. So what does the convolutional network do? It is a type of neural network that is best suited to treat images. So neural network typically are classifiers that are used that are used in two stages. First stage is a training stage, where the network adjusts the weight of the inner layer of a certain number of hidden layers to produce the desired outcome. And these inner layers, these weights, are adjusted until the output layer, so the desired outcome, matches the known outcome, which is known at the training stage. Instead, convolutional neural networks are different because there's no full connection of the hidden layers, but they're only partially connected. And in particular, each layer will refer to a specific region of the initial image. Through this approach, it is possible to compute it quite efficiently and also manage relatively large data sets. The training is typically, again, performed on this data set, is typically performed until the algorithm converges. So what do we mean by converge is that the difference between the target classification output and the prediction achieves a stable level. Here, there is the oscillation that we see in this simple error, which is typically an MSE error, very simple metric on different parameters though. It needs to be minimized to a certain threshold that we set to a few percent. So when we look at our results, between the prediction and the ground truth, qualitatively, we really cannot see much difference. So the prediction and the ground truth at a qualitative level do match relatively well, really well, I would say. And even if we look at the structure in 3D, we see how all the structures are well represented, and again, to a qualitative analysis, they seem more or less equivalent. However, we do need to find some quantitative parameters for the assessment of the method. And that's why we use the Sorensen-Dice coefficient. It's one of the metrics that we use. And the Sorensen-Dice coefficient tells us in two regions in space, and this would be a 2D slice, that the overlap matches how good the overlap between two areas is. So ideally, the Dice coefficient would be 1, because the set A here is the ground truth and the set B is the prediction. Our Dice coefficient, as you can see, is very high, and a Dice coefficient higher than 0.8 is considered an excellent overlap, an excellent segmentation outcome. But for two regions, which are the right and left lens of the eye. This problem arises because the lens of the eye is a very small region, and we have enhanced our algorithm to improve the segmentation of that specific region. And we do enhance it in the following way, by performing the first segmentation, calculating the Dice score, and then if the Dice score is below our threshold, calculated again with a neural network, an automated bounding box around the region, training the convolutional neural network again, and segmenting the region inside the identified bounding box. Here you can see the bounding box algorithm, how it creates a nice region surrounding the area. In general, these bounding boxes are typically overestimated since the anatomy it could be is comparable between patients. These bounding boxes are generally identified manually with a conservative estimate. In this case, instead, we did an automatic bounding boxing, and we're able to automatically identify and label the structures of our interest. And therefore, we are going now to train a network and try to improve upon the Dice coefficient and the segmentation of the lens of the eye. So this was our first project on the workflow in standard and hadron therapy. And the second system that we're working on is a microdosimeter and in general RB measurement tool that could be used for quality assurance, but to make sure that the symmetric beam quality of the before the treatment is what we expect. So given the importance of characterizing the RBE, we have simulated this geometry shown here, which is a telescope design typically used for similar applications. But it has, instead of encompassing two layers of the same type of detector, we have an organic simulator at the entrance and a thick silicon layer as the so-called E stage to measure the full energy deposited. This configuration allows to discriminate different radiation qualities and to characterize nuclear fragmentation, and potentially, if miniaturized, it could perform microdosimetric studies. If we radiate our system, as we've done in GM4, using 1 GeV carbon ions, 200 MeV alpha particles, and 50 MeV protons, we obtain the regions in a scatter density plot, plotting the dI and dx in the first stage as a function of the energy deposited in the E stage that are well separated. Confirming the capability of the system of discriminating different particles and of identifying nuclear fragmentation. If we then project all our energy deposited onto the NDX axis, we obtain this linear energy deposition spectrum, which can then be used to calculate microdosimetric spectra, which are nothing else than the square linear energy deposition as a function of the linear energy deposition. So as you can see, again, we have the peaks related to the radiation quality that we simulated, and we're going to calculate next microdosimetric spectra. Microdosimetric spectra are very important because they can be used to calculate directly the RBE using microdosimetric kinetic models generally accepted nowadays. So to conclude, there are molecular processes that control radiation-induced cell death that are not well understood. However, the linear quadratic model is a good approximation of the survival ratio, cell survival ratio during treatments. If we apply the model and use the model, we understand how the RBE plays a very important role in the effectiveness of the treatment. And therefore, treatments like charged particle treatments and proton therapy have the potential to achieve a better effectiveness in treating certain types of cancers. There is a need in hadron therapy particularly, to streamline the workflow, and that can be the process that can be improved through machine learning tools, as we've demonstrated for segmentation. What we plan to do is to incorporate our algorithm into the workflow, as well as to improve its performance for small areas. And finally, we've also studied the capability of a microdosimeter that could be used in QA, and we plan to continue optimizing the system and eventually building it and testing it. I thank you for your attention. Our contributors and the agencies who in part funded this work, and I'm happy to take any questions.
Thank you very much, Professor Di Fulvio. If there are any questions, please feel free to enter them into the chat.
Any questions, any curiosities?
probably give just one more minute. If there are any questions, I believe we also have your contact information available as well that they can email you with them. But if not, thank you very much for your time.
Thank you, Will, and thanks everyone.
It looks like we did get one.
Do you anticipate? Uh, I have to say that radiation workers. So I assume that you're talking about the microdosimeter that we're developing. I think that dosimetric approach is it could be applicable to in general to radiation workers and for personal dosimetry. However, in personal dosimetry, the inherently workers are not exposed to such high energy beams that require that level of knowledge of the primary beam and that fragmentation. That is really necessary to minimize the dose, the peripheral dose for the patient. Whereas for workers, current approaches tend to be conservative, which is fine in radiation protection and are generally accepted. Both in radiotherapy, standard radiotherapy and proton and charge ion facilities, charge particle facilities, the assessment is typically done with ionization chamber, tissue equivalent proportional chambers, and Bonner spheres, spectrometers for neutrons, and they tend to be quite reliable and accepted again at commissioning. Other questions? Okay, if not, I thank you again. Thanks, Will, for the introduction, and have a good rest of the day.